Well, good evening, friends, colleagues, and honoured guests. I am Professor Warren Turner, and I am Pro-Vice Chancellor for the Institute of Health and Social Care here at LSBU. And this evening, it's my great privilege to welcome you all here to the inaugural lecture of Professor Suzanne Bench. So we're joined tonight by, looking around the room, a great socially distanced audience. Thank you for braving travel disruptions and the weather to get here tonight. We're joined by some of Suzanne's current and former colleagues, academics, and her husband Jeff is also in the audience. So I'm sure it's going to be a phenomenal evening. Before I formally introduce Suzanne, I thought I would explain the nature of an inaugural lecture. An inaugural lecture is a new professor's first opportunity to formally lecture to their peers and to the public and to demonstrate their contribution to the academic discipline of theirs. Universities host them to celebrate with the wider academic community and society the achievements and esteem of their professorial faculty. An inaugural lecture is therefore a significant milestone in every professor's career. And we're here this evening to hear more about the contribution of Professor Bench's work and the impact it's having in her field. Now, and with no apologies for causing Suzanne great embarrassment, a little about Professor Suzanne Bench. Suzanne is an expert clinical academic critical care nurse of over 30 years' experience, combining clinical practice, education, and research. She is passionate about improving the health outcomes and experiences of patients and their families, specifically those who have experienced critical illness. Over the past 20 years, she has worked in general and specialist intensive care units at Guy's and St Thomas's NHS Trust, King's College Hospital, and more recently in intensive care at the Nightingale, Royal National Orthopaedic Hospital and University College Hospitals London, including during the height of the COVID pandemic. She currently practices at Guy's and St Thomas's critical care unit, predominantly supporting patients after leaving the ICU. After working at King's College London for 20 years, completing her PhD in 2014 and a postdoctoral fellowship in 2016, Suzanne took up the post as an Associate Professor of Nursing in the Institute of Health and Social Care at LSBU in April 2017, a joint appointment with the Royal National Orthopaedic Hospital, NHS Trust, where she was the Deputy Director of Research for Nursing. Suzanne was promoted to Professor of Critical Care Nursing here in April 2020 and was subsequently appointed as Director of Nursing for Nurse and Midwifery-led research at Guy's and St Thomas's in January 2022. She continues to work for LSBU 1 day a week, supporting PhD students and running a HEE-funded programme for research-active healthcare professionals outside of medicine. As a senior academic, Suzanne has held many leadership roles and has taught and supervised numerous students. She's authored over 35 peer-reviewed journal articles, many with clinical nurses, and is Associate Editor for Intensive and Critical Care Nursing Journal. Suzanne's also published a core critical care nursing textbook and is currently co-editing a second. Her research is geared to the needs of NHS patients and their families, and as part of LSBU's Ageing, Acute and Long-Term Conditions Research Group, she conducts research that addresses real-world challenges. Her research interests centre on survivorship after critical illness, critical care nursing workforce, and public and patient involvement in critical care research. She is experienced in qualitative, quantitative, and mixed methods research and improvement and implementation science methodologies, and is currently supervising 3 doctoral students. Suzanne's skills and abilities have been recognised in a range of awards and accolades, including Most Active Postdoctoral Researcher, NIHR CARC, Contributions to Research and Collaboration, LSBU, and Inspirational Leadership Nomination, NHS. Suzanne has a national and international profile. She serves on several strategic advisory boards and works closely with NHS England and professional bodies, co-authoring national guidance documents which influence policy and practice. Suzanne recently stepped down as chair of the UK Critical Care Nursing Alliance, and under her leadership, the Alliance produced several position statements and worked collaboratively to develop and publish multi-professional guidance during the COVID pandemic. Suzanne's also a long-standing executive board member of the British Association of Critical Care Nurses, amongst other commitments. Alongside her focus on critical care, Suzanne is passionate about supporting other nurses and midwives' engagement in clinical research. Suzanne's leadership at the RNOH resulted in a significant change in organisational culture across all disciplines and at board level. In April 2019, she became one of the first National Institute of Health Research 70 at 70 senior nurse research leaders, leading development of nurse and midwife research capacity and capability locally and nationally. During this time, she secured funding for LSBU to implement and evaluate the first ever HEE London funded NIHR postdoctoral bridging scheme for nurses, midwives and AHPs. She subsequently co-led her successful HEE London bid at LSBU in collaboration with KCL to deliver a whole suite of bridging schemes from internship to a postdoctoral scheme. Importantly for LSBU, Suzanne is a professor rooted in clinical practice, a passionate and visible champion of evidence-based practice and research. This is demonstrated in her success in shifting local organisational research culture and her focus on developing world-class clinical academic nurses, both within and outside of critical care, who can provide consistently excellent care, which improves patient experiences and outcomes, whilst also facilitating staff recruitment, retention and well-being. Ladies and gentlemen, Professor Suzanne Bench, with her inaugural lecture entitled Surviving Critical Illness, Intensive Care and Beyond. Suzanne.
Thank you, Warren. Well, I think I should just stop there, actually, because that makes me sound rather wonderful, and I'm not sure I quite live up to that. But anyway, thank you very much for that introduction. I'm going to share with you now some of the highlights of my career. I am aware that we have quite a diverse group of people in the audience, so I'm not going to go into any details around data or anything as part of this. But if anybody does want any further information about any of the information that I present or any of the other work that I do, then please do get in touch. I feel like I've actually made 3 areas of contribution to healthcare over my career. And they're the 3 areas that I'd like to focus on over the next 45 minutes, maybe, depending on how quickly I speak and how often I get taken off on a tangent. I hope you noticed in the corner, though, of this slide, a little square that says bench to bedside. And for those of you who are researchers will know that this is a term that we often use, where we talk about the most important research being the research that makes a difference for patients and their families at the bedside. And because my name is Bench, I feel like I can use this slogan and actually say that I feel I've made a difference and have contributed to research from bench to bedside. So let's start off, first of all, by thinking about the work around supporting patients and families after critical illness. Here's a picture of intensive care. I would say since COVID, many more people are aware of what an intensive care unit looks like. This isn't an intensive care unit that I've worked in the past, it's just a picture taken from the internet, but it does give you a sense of the complexity of care that a patient undergoes. I started work in intensive care in 1990, and I know some of you in the audience perhaps did maybe a bit later than that, but have been around for a little while as well. And at that time, when patients came into intensive care, they came in with a variety of causes, but all of them were really heavily sedated. We did everything for them. They weren't allowed to have very many visitors. We very much had a control over who came in, who did what. We didn't get them out of bed. Oh, goodness no, they were far too sick for that. And we really only worried about whether they survived until they left the intensive care unit. We really didn't think about what happened when those doors opened and the patient went out onto the ward. And we definitely didn't think about what happened to those patients and their families after they left hospital and went home. I'm really pleased to say that things have moved on from there. And nowadays, we keep our patients much more awake. We engage with them often, I hope, mostly. We get them out of bed as much as we can. We mobilise them as much as we can. But we also have a much greater awareness of the need for us to think about the impact of the critical illness on that patient and their family once they've left us, once they go back to the ward or go to the ward, and more importantly than that, once they return home to their family, to their carers, to their work and social and home life. Because there's no point in spending all of that money on intensive care, and intensive care is expensive, if we don't think about the quality of life that that person has afterwards. So what are the after effects of critical illness? Some of you will know this already, so apologies, but I'm going to tell you anyway. So they are grouped together under something called post-intensive care syndrome. And this post-intensive care syndrome happens not only for the patient, but also for the family. And it's considered to be an umbrella term for a collection of symptoms and problems that the patient and their family experience. Some whilst they're still in hospital, and some after they move into the community. Some for many, many years, and some never go away. So from a physical point of view, patients often are left feeling breathless, feeling very weak, feeling that malnourished. They have changes to their skin and their hair and their nails. They have a change in their sexual function. Basically, every part of their body can be affected by this critical illness. But more than that, they're affected psychologically, emotionally, and socially as well. A high proportion of these patients and their families suffer from anxiety and depression and other symptoms of post-traumatic stress after their critical illness. And this can go on for years and years. And they also have cognitive problems, memory problems. These patients, particularly if they've been more heavily sedated, often don't remember what happened in the intensive care unit. Some don't even know why they went in there. They have no recollection of that time. And therefore, they have this big blank in their memory that affects them. They often get, however, hallucinations and flashbacks that has a significant effect on them. They can get delirium. They can become acutely confused. And that causes all sorts of other problems as well. And when they go home, these things often make them isolated. They may be unable to or scared to go out to meet their friends and family again. They might be not able to engage in their normal social roles of parent or husband or wife. They may be unable to go back to work. So I hope I'm painting quite a bleak picture, because bleak is what it is for many of the patients and their families that leave our critical care units, even today. One area that I'm particularly interested in is the area of fatigue. Now, fatigue has really raised its profile as a symptom of COVID-19. And particularly for patients who've been critically unwell with COVID-19. But along with some colleagues, Fwadja, who's here in the audience today, and other colleagues from King's and Oxford, we did some work pre-COVID looking at the prevalence of fatigue after critical illness for any patient. And what we found from a review of the literature is that up to 90% of patients experience fatigue after a critical illness. And fatigue isn't just not sleeping well. It isn't just feeling a little bit tired and I can't be bothered to go to the pub tonight. It's described as an overwhelming sense of exhaustion that completely wipes people out. People describe it as feeling like they're filled with concrete and they can't move. And this fatigue has a significant impact on their lives. And yet, we have to date been very bad at recognising fatigue and assessing fatigue in a holistic way. There are tools out there that we can use to recognise it, but none of them have been developed with critical care patients and their families. All the tools that we use today have been drawn from other population groups. So we know fatigue is a problem in patients, for example, with cancer and other long-term conditions, in inflammatory bowel disease, in Parkinson's. And all of the tools that we use today have been drawn from these groups of people and applied to patients who are recovering from critical illness. So we don't actually know if they are the right tools to use. A couple of them have been formally validated in critical care, but as I said, none of them have been developed with patients, focusing on what they see is the impact of fatigue on their lives. So we undertook a qualitative study looking at fatigue in a little bit more detail. We talked to people across the country, asking them about their experiences of fatigue after critical illness and what they do to help. From their own perspective. And what we found was that basically it's different for everybody and that actually it has a significant impact on all aspects of life. But there's certain things that worsen it. And actually one of the things that makes it worse is a lack of understanding by family, by friends, and importantly, by healthcare staff. Healthcare staff often don't ask about it, or brush it off as something that, oh yeah, you're bound to feel like that. It will go away in a while. But we know that whilst it does improve over time, very few of these patients return completely to baseline. So actually that really doesn't help. So we've recently got some additional funding through Oxford Brookes University actually to do some further work, developing an intervention, working with patients to develop this intervention to help them self-manage their own fatigue. And we're just about starting that work now. And the little poster that you can see in the corner here, over here, I don't know if this has got a pointer. Is that a pointer? Oh yeah, there, look. That's our advert for patients to come and join us, to work with us, to develop a way of assessing fatigue and a way of developing a toolkit to help patients manage their fatigue. Oh, I've gone the wrong way, apologies. So fatigue is one of those symptoms amongst that myriad of other symptoms that I talked about. But the other question is, we know that patients after critical illness suffer all of these problems. We also know that patients after a critical illness often struggle in the community to get the right support. And we also know that they have all these symptoms for very many years and what I've just described. But what about after a COVID critical illness? Is it the same? Is it different? We thought this was a really important question, along with some colleagues of mine here in the audience, Nikki, wherever Nikki's up there, and Alison, who's here. We worked together with two of our local community trusts, Central London Community Healthcare Trust and Epsom and St Helier Trust, to actually undertake a study looking at the experiences of patients who'd had a COVID critical illness and look at what their recovery journey was like and what they need from a rehabilitation perspective. And what we found was that actually, yes, they do experience all of these things that I've previously described, but actually we found these three key themes that were underpinned by the uncertainty and instability that was caused by the pandemic. The first one being the trauma that was enhanced. Being critically ill is traumatic anyway, but this trauma was enhanced by the fact of the reaction of some healthcare professionals. People described feeling like lepers, and people described being really scared that they might pass it to other people. So this really enhanced that traumatic experience for them and made the whole situation much worse. Human connections became much more important. They're always important. But a sense of communication was so important to these patients and yet was much more lacking. The fact that healthcare staff were wearing PPE, a lot of the general public were wearing PPE. You couldn't go out and meet people. You couldn't get any support. A lot of the community services were suspended or moved to hybrid or online type of services. So that human connection was really lost. Somebody described saying, one of the quotes here says, "Yellow masks, they're like bird beaks, ducks." I said to the lady in the bed next to me, we were giggling, I said, "Oh, the ducks have come to take us." And there was very much this sort of sense that they were in this sort of alien world with this lack of human connection. And the third most important thing to come out of this was the real challenge that they had in terms of navigating this real system of trying to recover during this time. And they really talked about the importance of having some sort of care coordinator. And actually this has been brought up in the past for critical illness, but the importance of that was really heightened. Having somebody that understood them, that knew what they'd been through, that could be that linchpin to direct them to the right places, and that they could contact and support them. But one of the other things that came out of this was the fact that they wanted information. They wanted to know what was likely to happen. And a subset of these people went to community rehabilitation centres, and they had really high hopes for these community rehabilitation centres. And quite often their hopes were dashed when they got there, because they were sold to them as places that they were going to get, you know, good physiotherapy, occupational therapy. They were going to be helped to recover physically, psychologically on that path. But that often didn't happen because of the pandemic situation. So these people were left wanting, and again were feeling very isolated because they couldn't actually even see their family and friends. So they might have actually been better going home in the first place, or at least they'd have had their family and friends around them. Because family and friends are often the ones that pick up the tab, pick up the gap in service provision that we know is there. They're often the ones that call the GP 10 times a day to try and get an appointment, try and make sure that the medications are sorted, and try and arrange sort of support groups, etc. I know you can't see this slide, but it's supposed to, and I've stolen it from Doncaster and Bassett Law Teaching Hospital, so just giving acknowledgement to them. But I think it's a great infographic, because what it shows is the pathway of contacts that somebody who comes into intensive care experiences. And I think it really demonstrates the complexity in terms of all the people that are met, all the services they come into contact with, and why it's such a complex system to navigate. There's been a lot of work in recent years to try and make things better. So way back in the year 2000, a document was published called Comprehensive Critical Care. Paul's nodding his head, he remembers that. And this document was the one that really started the change, I would say. It was the one that recognised that critical care doesn't only happen in the walls of ICU. People are ill outside of ICU as well, and that we really need to open the doors, and we need to also acknowledge that we need to support patients, families and staff throughout the whole critical illness trajectory. Following on from that, there was a document in 2007 produced by NICE, the National Institute of Care and Health Excellence, that's what it's called now, and called Acutely Ill Patients in Hospital, which again made some recommendations for recovery. And that was followed up quite soon after by really a key document called Rehabilitation After Critical Illness for Adults. And this was the first document really that laid out a roadmap of what patients should expect, not only after they leave ICU, but right from the first day that they enter the doors of the ICU, to try and ensure that we preempt problems, we assess patients appropriately, and we work together in a multi-professional way to meet the needs of the patients all the way through. And latterly, I'm really proud to say, as chair of the UK Critical Care Nursing Alliance, I was part of the working party that put together this document that you see here, Life After Critical Illness, which was a collaborative document produced by the Faculty of Intensive Care Medicine, Intensive Care Society and the nursing organisations, that again provides more detail about what these patients and their families need after critical illness and how best we can support them. However, I'm sad to say that it's still not perfect. And one of the biggest challenges we have is around the funding situation, which we don't have funding in the right way to actually support the patients. So often the funding for a lot of the services that are laid out in these documents is still coming from piecemeal funding from the intensive care unit, and therefore it's still a postcode lottery. So there are services around. Most units now run some sort of critical care follow-up service, maybe 6 weeks, maybe 3 months after intensive care, for some patients who meet the criteria. Some places use assessment tools to recognise patients' needs and to put into place rehab plans. Some patients are given access to websites and recovery information, like ICU Steps, which is a charity run by former patients. And the critical care recovery website that was set up. But some patients will have fallen through the net and not receive any of this. It really is very much dependent on where you live, who cares for you, what your unit you're in, and what funding is available in those areas. One thing that comes through really strongly is the fact that patients still don't get the information that they need to actually recover well. And information is absolutely critical. We often see information as a very simple intervention that doesn't have any significant effect if done well or if done badly. But what we know from the literature is actually information given badly by the wrong person at the wrong time in the wrong way can have a significant negative effect on somebody. And so we do need to be really careful about what information we give and how we give it, and who's going to give it. And so I did some work for my PhD. This was the focus of my PhD, really, information provision. And this was based on the fact that actually if we give information to people in the right way, then that will help them to understand the progress they've made, understand what to expect going forward, and help them to set the right goals, realistic goals for the future. And so I developed, when I look back now, a terrible name for a document, which we called the UCDIP document. I mean, how awful is that? But anyway, it's really hard sometimes trying to find those acronyms for studies. But this was called the UCDIP study. And what we did is we worked with former patients and staff to develop 2 documents, because one of the things that we identified very clearly from our qualitative work was that patients and relatives need different information at the point of discharge. Patients often know nothing because they may have been sedated. Family members often know a lot. So at the point of discharge from ICU, they have very different information needs. And yet in the past, we've often lumped this all in together and said, here's your information booklet, and just left them to it. Or some people might give them more information, some may not. Anyway, so we developed these 2 documents and we piloted them, and we did a pilot randomized controlled trial to look at whether they were valued and whether it was feasible to deliver them. And we found that they were valued by patients, but actually what I found even more surprising was how valued they were by the ward nurses. And the reason they were valued by the ward nurses is because they included a 1-page patient discharge summary that wrote in lay terms, simple English, why that patient came in, what did they come in, when did they come in, what happened to them in ICU, how did they respond, and what are they like now. The patients often never get that information, or they might get it verbally, but of course they don't remember it. And the ward nurses found this information incredibly useful because they said, we often look through the notes and we don't understand any of the language that's in the ICU notes. It's all, pressure support this and inotropes that. It's a completely different world. So that was really useful. The other really interesting part was we added in diary pages into both the booklets to enable both the patients and the families to start writing their own reflections each day or each week or wherever they wanted to, because we identified that they needed to understand that they'd made progress. And looking back and seeing where they'd come through to where they were was really important. And often, I won't say often, many units now do start diaries for patients when they're in ICU that are often written by the ICU staff or sometimes family and friends. But oftentimes these diaries aren't given back to the patient until they come to the follow-up clinic, maybe 2 or 3 months later. And so many patients are still left with this gap in terms of what they know. It's also important to remember that actually GPs need information as well. Another study that we did looking at, did some focus group work with GPs and patients, showed that often GPs had no understanding of the sequelae of critical illness. They weren't afraid to say that, many GPs traditionally trained had never spent any time in ICU. And so why would they know anything about ICU and what the potential after effects of a critical illness are? And therefore, they often didn't pick these patients up. The patient might go to them 3 months later with anxiety or whatever, but they never linked those two things together. So they never referred them to the right people. GPs get hospital discharge information. Hospital discharge information is usually written by the most junior doctor on the ward who has no idea what happened to the patient when they were in ICU. More and more hospitals now, more and more ICUs now are writing discharge summaries direct from the ICU to the GP. But when we looked at the content of that, what we found was often it was very much about what had happened in ICU. So again, it was talking about the level of ventilation this patient received, the level of inotropic drugs this patient received. When what the patient and the GP wanted to know was, you've changed my medication. Do I need to keep that medication it is now? Or do I need to go back onto the medication I had before? What did you do in the hospital? What else does the GP need to do? Where do I need to be referred to? So we need to understand what the needs of the individuals are. And this is where the patient discharge summary that I talked about a couple of slides ago as part of our UCDIP came in really handy as well, because we developed a training pack for staff to use to write these discharge summaries. We translated all medical terms into lay language, and we asked the nurses on the units to write these discharge summaries so that the patients could take them with them. They could share them with who they wanted to. They could take them to the GP, and they both then had an understanding of what had happened to the patient. I think I missed a slide. Oh yeah, because this quote from Albert Einstein says it all. If you can't explain it simply, it's because you don't understand it well enough. And what both the GPs and the patients said to us is they don't want fancy language. They want to be told in simple terms what has gone wrong and what is needed. And the final bit of this section, I'm definitely going to be over, but there you go. The final part of this section is something that's really important to me, is the fact that throughout all of the work that I've done it with patients and families and staff. Because actually, if we're ever going to develop interventions that are going to work for patients and families and staff, we need to know what they need, and we need to work together with them to develop something that's feasible to deliver and that is given in a way that people want it to be given. So co-design and co-production are sort of common terms that are bandied around, but essentially it's about working with people on an equal footing in a way that recognises the value of everybody's voice so that we end up with something that is useful and cost effective as well, because it takes a lot of money to develop these things. So if you develop something that's not going to work, then that's a waste of good NHS and social care resources. So I'm going to move on now to talk briefly about the next section, which is about supporting staff, because of course it's all very well to focus on the patients, but if we don't also focus on the staff, we won't have any staff to care for the patients, and that won't be very good for patient outcomes either. So I think the first most important way that I feel that I've contributed to supporting staff is through the many years of educational provision that I've given. So I started as a lecturer practitioner at the University of Greenwich and Greenwich Hospital when it no longer exists. It's probably flats or something now. And we moved into Queen Elizabeth Hospital before I left there. But I worked there as a lecturer practitioner in 1998. And from then onwards, I moved to King's College Hospital and King's College London. And for all of those years, over 20 years, I ran the intensive care course. And it's been very interesting moving back to Guy's and St Thomas's more recently. Everybody keeps coming up to me and saying, you taught me on my ICU course. And they're all like band 7 and band 8 now. So it definitely makes you feel old. Education is so important, and we really need to think about how we educate people for the future. The way we educated nurses in the past doesn't necessarily mean that that's the way we should do it for the future. There's been a lot of change. There's been a lot of change, obviously, through COVID with hybrid ways of working, new models. And we've actually done quite well, dare I say, in critical care around this, because we have attracted government funding to increase educational provision for critical care nurses, and also, really importantly, to increase the number of practice educators in the critical care unit. Because there's no point increasing the number of places on an ICU course if actually you haven't got enough staff on the shop floor to mentor and supervise these people appropriately. So we have done well there. And we have developed competencies over the years for people who specialise in intensive care. So there's national competencies now, and we're just digitalising those at the moment. I say we. The UK CCNA is part of that. But it is important that we continue to look forward, and we continue to look. When I first started, education was very much happening in the trust, in the hospitals as they were then. Then it was all brought into the university. Now we're starting to see much more of a sort of moving back and working together again, recognising that actually people on the shop floor are the people with the clinical expertise. And we need that clinical expertise, but we also want it driven by theory and evidence as well. So we need to work together between the clinical academic institutions to make this work. I couldn't not do this lecture today without mentioning the British Association of Critical Care Nurses. And Ian is here today. I told you were on the picture, Ian. Actually, you look much the same. But I have to say that many of the people on this picture don't look as they do now, me included. So I think we need a little bit of an update of the pictures here. But anyway, these are my colleagues currently on the national board for the British Association of Critical Care Nurses, which is a charity which really focuses on supporting critical care nurses across the UK and internationally. And most recently, we have membership for veterinary critical care nurses. And you would be amazed to know the overlap between veterinary critical care nursing and human critical care nursing. Really interesting. But we run study days and conferences, and we provide grants for nurses for research and projects and to attend things. So a really, really important group of people. And I've been in the BACCN since I started my critical care career. I can't ever see me leaving unless they kick me out. And the BACCN is part of the UK Critical Care Nursing Alliance, along with all of the other professional bodies for critical care nursing, so the RCN, the National Outreach Forum, the Paediatric Critical Care Society and the Intensive Care Society. And together that UK CCNA means that we have got a really strong voice with which we can use powerfully. And we've used that definitely over the last couple of years. And I happen to take up chairmanship. It's a 2-year period. In January 2020, How fortunate was that? So, but during that time, we used that power a lot to really lobby NHSE and the government to about things that we feel are really important, and collectively we have a strong voice. And one of the things that we've really focused on is staffing. Now, we know there's a national shortage of intensive care nurses and nurses generally. And there's been a big challenge put to us in the critical care world over the last couple of years about the numbers of nurses we have in the intensive care unit and whether we should have that number of nurses, because actually outside of England, in other places in the world, they don't have the same level of staffing. So do we need it? And of course in COVID, we were looking after 8 patients and we managed. So why shouldn't we be able to manage now? Well, I can tell you that we've just finished another study that looked at patient safety from a nurse's perspective, and I haven't put that on the slides, that had I put some of those data up, and I haven't put it up because we're still publishing it, but actually if I had put that up, you would see a very good reason why we shouldn't be caring for 8 patients. And none of that data is reflected in the incident reports because nobody had time to report incidents during COVID. Anyway, so for ICU patients, generally, ICU patient who has advanced ventilatory breathing support, multi-organ failure, your traditional intensive care unit patient has at least 1 nurse to care for them, sometimes 2 if they've got lots of equipment and they're very sick. And if you're a high dependency patient, then, you know, maybe cardiac failure or you've just come out of major surgery and you need monitoring, then at least 1 nurse to 2 patients. And these standards are set down in our guidelines for the provision of intensive care services, which was last updated in 2019. This is a professional document. And the UK CCNA wrote the chapter on this. However, there's no real evidence for this. And that's where we come unstuck, really. These staffing numbers are based on tradition. They're based on expert opinion about what we think we need. And as I said before, during the pandemic, we really had to fight back against why we shouldn't move away from 1-to-1 and 1-to-2 nursing going forward. And we wrote various position statements and contributed to advice on nurse workforce models during COVID. But even before COVID, we were already recognising that perhaps the workforce of yesterday is not going to be the right workforce strategy for the future. We were already seeing that actually our patients' needs were different. I've told you, we get patients up more now. We allow physios to do more to our patients. When I first started in ICU, the physios used to walk in and say, "Oh yes, they're very sick, I'll come back." And then they'd come back tomorrow and they'd say, "Oh yes, they're very sick, I'll come back when they're on the ward." And now physios come in and they assess the patient and they do some amazing things, and they'll get the patients up and they'll put speaking valves on the patient. And occupational therapists come in and do work with them. And speech and language therapists come in, and psychologists come in, and we work as a much broader multi-professional group. So we know that the workforce configuration of the past is not necessarily going to meet the needs of the future. But we also want to know what the evidence is for new workforce models. We don't want to just change without the evidence, and that's what we're pushing back on at the moment. So we did some qualitative work pre-COVID. We got an NIHR grant to do some work pre-COVID, looking at looking at the organisation of nurse staffing, and also we managed to use some of that funding to collect some data during COVID as well. And I'm really pleased to say that we've just got funding again for a HSDR grant from the NIHR to evaluate the introduction of new staffing models in intensive care going forward. And the chief investigator for that is my colleague Natalie Patterson, who's a Florence Nightingale Foundation chair at the University of Hertfordshire. So watch this space. Having said that, we do recognise that we can't wait for research outputs. They don't come for a long time and things move on. So things will change, things have changed. Many units people work in, they're already trialling new ways of working. But my message is, if you're going to make a change, make sure you evaluate it. And evaluate it from the patient outcome perspective, from the staff outcome perspective, and from the family outcome perspective. Okay, finally, we're going to talk about something a little bit different than critical care. And that's my other passion, which is about supporting the capacity and capability for nurse-led research. I thought I'd go back a bit first, though, and share with you some old photos. So the first one over here is a picture of me as a student nurse. Nice fringe. I'd clearly lost the fringe by the time I did my intensive care course a year later. And the middle picture is a picture of me qualifying with my ICU course and with my lecturer. I always wanted to be a nurse. I never wanted to do anything else. And I was really, really, really inspired by my nurse lecturers. And by the time I'd finished training, I'd already decided I was going to be that person. And so I was really, really proud when I finally became a lecturer practitioner. And I was even more proud when I became a doctor of nursing, when I got my PhD in 2014. And just to embarrass him, that's my husband there. And my daughter, who's chosen to go and see the Red Hot Chili Peppers in Manchester tonight. But at this point, and up to this point, I'd really struggled. And the reason I'd struggled is because I'm really passionate about keeping up clinical practice, teaching, and doing research, because I think you can't have one without the other. You know, to get good patient outcomes and experience, you've got to understand the needs of the patient, so you've got to be there. You've got to be helping people to keep up to date and to teach them. And you've got to be generating the evidence and applying the evidence to practice. And I fought over the years with many people. I'm not going to name the institution, but one institution I worked at told me, don't worry, once you're a lecturer, you'll realise you don't have to practice, it's not important. And my response was, well, when I feel like that, that'll be the point at which I have to leave. Because at the time I was running the ICU course, and how on earth can you run a clinical course without being clinical, is my view. And even when I got my PhD, I then tried desperately to get a clinical academic appointment. And really struggled, and everybody said, oh, we'd love to have you, but we've got no money. And so I was really, really chuffed when actually I took up an appointment at South Bank University, which I thought was a really forward-thinking appointment because it gave that opportunity to combine education, practice in an NHS setting, working at the Royal National Orthopaedic Hospital, and as the Deputy Director of Research for Nursing. So it gave me that opportunity to bring those things together. But my proudest moment of my career, I have to say, is when I was promoted to Professor of Critical Care Nursing in March 2020. Some of you might say, well, that's really not a great time to be promoted. At that time, I was working as a clinical bedside educator, leading the education team on the shop floor at NHS Nightingale at the Excel. And for me, that was the point at which all of the elements of my role came together. And it showed me how important it is to have all of those things. The importance of research and nurses of research was really demonstrated, wasn't it, in COVID? It's really heightened people's awareness. But also having people that can utilise that evidence, can apply it on the shop floor, can teach people who'd never walked into an ICU before, let alone a made-up ICU in a conference centre with no facilities or support. So this was my proudest moment. So why is this so important? Why is it so important that we engage more nurses and midwives in research? Well, we know that research active organisations actually provide better patient outcomes. And we also know the nurses are the biggest workforce, and therefore they're in the best position actually to develop the research questions that matter to patients and their families and to staff, because they're there on the shop floor. But we also know there's many barriers to nurses doing that. Confidence, knowledge, skills, capacity, time. Many nurses, even now, didn't have any research training in their nurse training. And even those that did are facing a system where many middle managers who are doing appraisals never had research in their training. And therefore, that's a real barrier to facilitating engagement. But there is a national drive in England now to increase nurses engaged in research, and this has been demonstrated by national leadership positions, you can see from the pictures above, and by the publication of the Chief Nursing Office for England's Making Research Matter strategic document in November last year. So we're on the right track. And of course, Warren already talked earlier about the fact that here at LSBU, we were fortunate. I worked with King's and also other colleagues here to put together a bid for running a Health Education England schemes to support healthcare professionals outside of practice who want to develop a clinical and academic career, that they don't have to move into a university like I had to. That's the only choice I felt that I had, but instead they can stay in clinical practice and we can support them to develop research careers at the same time. So we are coming to the end now. As Warren said, I was proud to be awarded one of the NIHR 70 at 70 senior leadership places, which was 3 years funding for 2 days a week to develop capacity and capability for nurses, both locally at the Royal National Orthopaedic Hospital where I was based at the time, but also working nationally with colleagues and regionally to really drive this agenda forward. But I really do want to say that it can not only be about what NHSE do or what the universities do, but I think it takes real commitment from our chief nurses in our trusts to make this happen. And so I did want to just point out Professor Paul Fish, who's here tonight, and Avi Bhatia, the two chief nurses that I've worked with in my previous and current appointment, who I think are inspirational, have really led the way in terms of championing the development of nursing midwife research engagement. And we need more chief nurses who get it, more chief nurses who are like them, that support their organisations to develop leadership roles for this agenda. And just to finish, to say that my current role is as Director of Nursing for nurse and midwife-led research at Guy's and St Thomas's. Because this is what can be achieved. When I was at RNOH, I worked with clinical staff to help them write papers, to write up the work that they'd done, to develop projects, to present at conference, to grow their confidence, whilst also developing regional and national work as well. And this is my last slide. And I've put this in because this is the slide that I presented for my promotion panel to Professor. And you have to show how you're meeting the requirements of the academic framework and what you will do for the organisation in the future. And I just want you to focus on the future bit. So from a future point of view, I argued that I would maximise impact through the development of clinical academic appointments. I argued that I would lead interdisciplinary LSBU-led research to improve critical illness outcomes. And I argued that I would help LSBU develop as the go-to university for clinical academic nurses. And I hope what I've demonstrated to you this evening is that I've achieved that to some degree, although there's still a long way to go. Thank you for listening.
We do have a couple of minutes if anyone has any burning comments or questions they'd like to put to Suzanne before I invite Nikki to say a few words.
I'm silence everyone.
There we go, look at that.
That's what you do in an interview. just give so much information that there's no further questions.
Very good. Yes.
I was maybe going to ask what would be, in terms of patient outcomes in intensive care, what would one thing, if there was no question about funding, that you would change to improve patient outcomes?
I would change the outcomes in terms of, well, not so much in intensive care, but thinking about the recovery pathway after intensive care in terms of services we provide to help support patients re-engage in work and social and home life. Because actually if we can do that, that's got to be the best thing, because it saves the NHS and social care money, but it also increases the quality of life for that patient and their family. So I think that the outcomes we should be focusing on are those longer term outcomes, and the outcomes that matter to the patient. Can I be a husband or wife again? Can I go to work? Can I go down to my knitting club or to the cinema or whatever else it is that I want to do? They're the things that I think we should be focusing on, not does somebody survive to the doors of ICU.
Thank you.
Paul.
Firstly, huge thank you for everything you did at the ROH. We can't overemphasise the impact that having your kind of post in an NHS organisation has in terms of getting nurses going with research. It's just been absolutely transformational, so thank you. The other thing is, you know I'm a techie.
Yes. You're not going to comment on the quality of the slides, are you?
But I wonder, do you think there's any space for technology in terms of that bit around giving patients information, giving them support tools for the future? If we're not very good at giving people pieces of paper, is there technology that can bridge that gap?
Oh, without doubt. And I see Katie's here, and Kate is the follow-up nurse specialist at Guy's and St Thomas's, and they developed a digital recovery pathway and a digital diary, and you know, all of those things that we used to do on paper are naturally becoming digital now. And that is the right way to go, but we also need to be aware that not everybody is digitally competent. And so we need to think about the people that either don't want to engage digitally or can't engage. That's actually quite a hard word to say, digitally. And we need to make sure that we've got a toolkit that offers something to everybody. So yeah, you know, more and more, there's an app for everything now, isn't there? And that is good, and it's great that we can use apps and iPads to connect people to recovery services and to the websites while they're on ICU, and they can have their little iPad and everything. But people want the human connection as well, and I hope that we'll never be in a situation where we can replace us as nurses for a robot on an iPad.
Thank you. So, do you have your hand up? Yeah.
Yeah, can I ask Suzanne, with your work around safer staffing in ITU, did any of that look at what happens outside of the ICU?
So no, it focused on the ICU, but what came out of the data was that you can't look at that in isolation. Actually, what you have to do is look at what's happening in terms of the context of care around it. So for example, what works for one unit where perhaps you've got a very large hospital with a lot of support services and people that sort of pop in and out. One workforce model will work very well for that. But actually, if you're in a DGH with a 4-bedded ICU and no other support anywhere else, that same workforce model won't necessarily work. It also depends on the expertise of the other staff that are around as well, the medical staff and other healthcare professionals, advanced critical care practitioners. We've got more and more of those now. And all of the other advanced specialties that are coming into ICU. So the degree to which you've got those, the degree to which they're competent and they work together, all makes a difference in terms of what works. And that's why the new study is taking a realist evaluation approach. So realist evaluation is about what works for who, under what circumstances. So it's about saying, taking different case studies and looking at the different models of what's working, how, where and when, to actually bring that all together to try and understand the sort of core. what is core and what can be adaptable.
Thank you so much, Suzanne. A question that I ask myself and that I get asked very often is, how do you measure outcomes for these people in a way that is applied to what is happening at business planning, business case level, to form these clinics and these services to be what they need to be? Because we know that so many of the outcomes are quality addition, qualitative stuff, and there's reams of qualitative information about the way that these services impact on people. But what would you advise in terms, so I've often asked from hospitals and centres that are creating clinics from scratch or looking to develop their services, what should they measure? How should they measure it? How can they prove to their service managers that this matters? In a bricks and mortar way. And I'm wondering what you'd advise.
And it's so hard, isn't it? Because what they really want is those concrete outcomes. They want to know how much it costs, how much time does it take. But actually, can you really put a cost on the way somebody feels and the experience that they have in their life after? It's really difficult to do that. So I'm not sure I've got the complete answer, but what I would say is that there is work going on at the moment. So we're part of a national working group for NHSE looking at rehabilitation outcomes after critical illness. And so people from the adult CRG, clinical reference group, are coming together from a range of different perspectives to try and nail down some of those things, which include the hard outcomes like cost, but also almost quantify the qualitative aspects as well, if you see what I mean. And you can do that. I think you can quantify some of the qualitative aspects, and that's what we need to do. But we need to have enough of that evidence from the qualitative work. And often qualitative work is written off, isn't it? Oh, that doesn't matter, it's just what the patient said. But we need to recognise the importance of the qualitative data more in saying this is what matters to the patients. And if thousands and millions of patients says that's what matters to me, then we can make that an outcome that can be measured.
Anyone else? No, thank you. Nikki, I think I'm asking you to give a final statement and to wrap up. And then after that, if everyone could then head up to the mezzanine for a bit of light refreshment, I think, Suzanne, and networking.
Does that mean a glass of wine?
A glass of wine, I hope.
Or two, as we cater for a lot more people that registered, and because of the transport, you could have less.
Yeah. Professor Nicola Thomas.
Oh, thank you. Yes, it's a very tough gig, this, because I'll come between a fantastic presentation and the wine and food. So, but I just wanted to say a few words, Suzanne, on behalf of everybody. It was absolutely fantastic, and as always, just to say, I've known Suzanne, 5 years, I suppose, being a fantastic colleague. I was going to say friend, but I hope it's a mutual thing. But what always comes out, Suzanne, is your passion, and you've just said it. It's about what matters to people who survive critical illness, and that's the most fantastic thing. And also I was struck by all the collaborations. It's quite extraordinary. You put all those papers up there, and I know some of them. I know CLCH, whatever that is now, community, whatever that thing is, and St Helier. I was at St Helier today, and of course guys in St Thomas's and UCLH and RNOH, all these places, and all the people you've supported, the staff, and of course the patients, and that's what's so fantastic about your work. And you're absolutely grounded with it. And I think what it's about, Warren, and maybe we can lobby you later, but actually it's all about, as you keep saying, it's about practice, education and research all coming together, which is absolutely critical. And if we are going to have professors of nursing, and you and I think the same of this, but we have to have the three together. We have to show that we can still be a kidney nurse, a critical care nurse. We can still, we can be an educator and we can be a researcher as well. So you said right at the top, you said, actually it makes me look rather good, all those things, but actually you really are rather good and wonderful, and you've shown that tonight. So many congratulations to you. We have something here, which is... I know. Look how wonderful this is. So I don't know if Neil is there, but I think he's the... Well, I don't know if people can see that. I'll stand out the way so that maybe people can take a photo.
Lovely. Where are we going to put that? Thank you very much. That's great. Thank you. Thank you, Neil. Oh, it's going to take a picture now. Take it at the end. Oh, God.
Fabulous. Thanks, Nicky.
Yeah, brilliant.
Thank you.